Hello, everyone. Can all of you hear me well?
Yes.
Okay, so I welcome you all to this webinar, and I'm hopeful that this is going to be very informative. Pediatric neurosurgery has always been a center of attention for everybody because it is delicate, and recently a lot of work has been done with regard to pediatric neurosurgery. Now, in terms of tumors, we have a lot of markers, and the treatment modality has changed quite a lot. And because of that, the outcome has also significantly improved. And this is one of the reasons. And most people find pediatric neurosurgery a bit daunting, difficult, but I'm sure we have our experts over here who are going to help us understand the common pathologies better and help better plan and manage such patients. And I'm sure these are going to be very interesting talks. So everybody stay tuned, and we'll be starting our session. So first of all, we have Dr. Hasan Syed. I think he has joined. Yes, he has joined as well. He is a professor of pediatric neurosurgery in US, and he'll be talking about craniosynostosis. So Dr. Hasan Syed.
Are you able to see my slides?
You have to start screen sharing.
Okay. Hopefully you can see it now.
Yes.
Great.
Clear.
Well, first of all, thank you very much for the invitation. I'm very excited to speak to you all, especially for the committee to organize this, and Dr. Salman as well. As you mentioned, I'm a pediatric neurosurgeon. I find pediatric neurosurgery extremely interesting and rewarding, partly because of the breadth of pathology that we see in this field, as you all know. So I've been asked to speak about craniosynostosis, so I'm going to briefly talk about this. I think I have about 15 minutes or so. So I'll talk about the diagnosis and management of craniosynostosis, and I'm happy to answer any questions that come up as well. Really, I want to cover three things. One, the history and evolution of craniosynostosis, provide an overview of head shape evaluation and the types of craniosynostosis that trainees will see, and then compare operative management very briefly. Again, this topic can be, can consume a lot of time, but I just want to hit the highlights for you all. I found this, in my research, just in terms of craniosynostosis historically, this quote pretty interesting. This is from Dr. Przanski, who was a craniofacial surgeon and actually an orthodontic surgeon in Chicago. And basically he quoted this saying that craniosynostosis is really intriguing because it's really the drama of nature, of the stresses and the storm between the growing brain and the rigid skull itself. And this really underscores the pathology itself and how we treat it, and again, the evolution of treatment that has occurred over time. This is something that came out in the 1800s. This was a question from a child's parent: can you not unlock my poor child's brain and let it grow? And in response to this, Dr. Lane from San Francisco performed the first surgery for premature sutural closure in 1892. Of course, surgical technique and the technology available was limited at that point, and this child unfortunately passed away after surgery. But really, because of this and other cases and the morbidities associated with these surgeries, this type of surgery was shunned upon. And in fact, again, in the late 1890s, in a large pediatric international conference, there's one pediatrician who even said, quote, "The hands take too frequently the place of brains, and such rash feats of indiscriminate surgery are stains on your hands." So a pretty marked quote that really ended the surgery for this pathology for nearly 3 decades. until the evolution came about in terms of safe surgeries. And a resurgence of interest in this type of surgery occurred in the 1930s, also from Boston, which popularized the suturectomy. There were significant advances in anesthesia, blood transfusion, surgical techniques, which really decreased the morbidity and mortality for treating patients with these surgeries. And that's where we see things going forward. We also know about modern endoscopic strip craniectomy techniques. This was popularized and written in the 1990s by Jimenez and Barone, who recognized the limitations of the approaches and proposed a novel technique with simple suturectomy followed by helmet therapy. This is something that, at least in North America, is really advocated for in terms of a lesser invasive type of modality for treatment. Treating kids early on also prevents secondary deformity, since it's done so early. So how do we evaluate head shape? We really want to look at the history in terms of head shape at birth, if there is a head turn preference, whether there's an association with torticollis or family history of craniosynostosis, and of course the physical exam findings, specifically with a cephalic or cranial index, the position of the ears and nose and whether they're symmetric or asymmetric, what the forehead looks like, and whether there's ridging along the cranial sutures on palpation. Certainly, for confirmation of the diagnosis, various imaging studies are done, most typically a CT scan, again, here in North America, to confirm that diagnosis. If you look at the picture on the right, it really shows you sort of the morphology of this pathology. You have scaphocephaly, or a long-shaped head in the top left, associated with sagittal synostosis, trigonocephaly, which is associated with metopic synostosis, and so on and so forth. It's also important to differentiate between deformational positional plagiocephaly, which is associated again with positioning and not pathologic, or not surgery is not needed for this, obviously, and there's no neurodevelopmental consequences specifically for positional plagiocephaly. Looking at the cephalic or cranial index, this is the biparietal diameter divided by the occipital frontal diameter. And normally this is between 76 and 90%. One can use calipers to help with these measurements, and that also aids in the diagnosis of certain types of craniosynostosis as well. When we think about the surgical management of craniosynostosis, we think of open surgery versus suturectomies, and there's a variation of these types of surgeries depending on the center and the experience as well. This is a child undergoing an open cranial vault remodeling for sagittal synostosis at a relatively earlier age, between 6 to 9 months, versus a suturectomy, which we perform before 3 months, again, a lesser invasive surgery. So just some case examples. This is a 5-month-old boy with scaphocephaly with imaging studies that confirm the diagnosis of sagittal synostosis. Again, you can see the long-shaped head, the frontal bossing, as well as the occipital bulleting that we see in these types of cases. Again, that's because of the nature of the pathology. The skull can't grow perpendicular to the fused suture, and so a parallel growth is seen. And then again, we performed an open cranial vault remodeling by removing the fused suture and the biparietal craniotomies, as well as barrel stave osteotomies as well. And you can see a post-op scan roughly about 3 to 4 months later, showing how the skull has become more round. There are some skull defects with this type of surgery that typically fill in over time, but something that we monitor as well. So this is a child, a 6-month-old girl, an example of a child with a unicoronal synostosis, and you can see that there's ipsilateral frontal bone flattening on the right side, and compensatory contralateral frontal bulging. This is also associated with a shortening of the anterior cranial fossa and the elevation of the sphenoid bone that you can see on the X-ray in the center as well. I find looking at the nose, the tip of the nose, to be very helpful. As you can tell, the tip of the nose points contralateral to the affected suture, and that's sort of a hint that you can tell by which to make the diagnosis. And again, an open surgery in the form of a bifrontal craniotomy and orbital advancement as well. This can be done, at least the frontal, the orbital advancement, unilaterally or bilaterally, just again, depending on the techniques that are used. The other thing to note, especially for the trainees, is the pathognomonic harlequin eye deformity that you can see on the X-ray, and that's associated with the elevation of the superior lateral corner of the orbit. So also important to keep in mind. We talked about the facial deformities of coronal synostosis. This is again just depicting that in a figure. The fused suture on the right side, the compensatory bossing on the contralateral side, the harlequin deformity, and again the nasal tip deviation, and potentially how severe it is, a chin deviation as well. This is an example of the child, a 4-month-old who had bicoronal and sagittal synostosis, and we'll talk about the pathologies and other associated genetic conditions as well, very briefly, but important to also consider genetic testing, again, if it's available, something that we do here, at least in North America. This child was treated in an open manner as well. The parents wanted an open correction in order to avoid helmet therapy as well. And these are some postoperative imaging afterwards showing a pretty good correction in terms of the head shape itself. We talked about positional plagiocephaly. I bring this up as well compared to lambdoid synostosis. Lambdoid synostosis is the least common pathology seen in craniosynostosis, but something to be aware of because that can require surgery versus plagiocephaly. You can see that a trapezoid skull shape is seen with posterior displacement of the ipsilateral ear and ipsilateral mastoid bossing, as well as a contralateral occipital bossing that can be seen with lambdoid synostosis, as compared to plagiocephaly, which mirrors a parallelogram shape. Again, that does not require surgery, but important to differentiate the two as well. So indications for surgery. Wide variations based on management. The treatment really depends on the age of presentation, the location and number of premature sutures that are fused, the severity of the deformity, and whether or not there's a presence of a craniofacial team and how that plays into the center itself. Really, the main indications are to correct the skull shape, but more importantly, provide adequate growth for the brain. So I'm going to talk about, what we do here, endoscopic suturectomy, usually within 4 to 12 weeks of age. If a child can get to our center during that time, that's what we usually recommend. The pros are, again, it's less invasive, less blood loss, shorter hospital stay. The con is that a helmet, cranial molding helmet is needed from anywhere from 6 to 12 months, and that's important to consider based on what's available and what the parents are comfortable with. Contrast that to CVRs, or cranial vault remodeling surgeries that are done at an older age, slightly longer hospital stay. Usually blood transfusions are required, so that's something to keep in mind as well. This is just a slide kind of summarizing the helmets and the pathway to that. Baseline measurements prior to the OR, a 3D scan 1 week post-op, and then the helmet is must be worn for 23 hours a day and adjusted every 2 to 3 weeks. So it is a commitment for the parents, and there is a cost associated with that as well. Looking at the epidemiology of craniosynostosis, it occurs usually 1 in every 2,000 to 2,500 live births. Single sutures are the most common, but multi-sutures can be seen and more so associated with genetic conditions or syndromes. Sagittal synostosis is the most common, followed by coronal and then metopic. Also important for the trainees to understand that normal closures of the sutures, particularly metopic synostosis, so you can see, closure of the metopic suture, which you can see between 3 and 9 months of age. Sometimes you will see kids who have metopic ridging, but not pathologic. In other words, there is no trigonocephaly, there's no hypotelorism associated with it. Again, that's just some ridging and a different type of phenotype, but doesn't necessarily require surgery. The other sutures usually close much later in life. I'll skip this slide for the interest of time, but etiology, we think about various genetic mutations. More commonly, single suture closures are sporadic, and there are craniofacial syndromes that are beyond this scope of this talk that are important to know about as well. So again, timing of surgery, largely 3 to 9 months is considered optimal. It's passive post-op endocranial remodeling is also seen. You have the malleability of the calvarial bone, and you minimize facial dysmorphisms. Later in life, the calvarial bone is less likely to be molded. There are unpredictable reossifications, and the facial dysmorphisms persist or progress. So again, in our center, less than 4 months, we typically promote endoscopic techniques followed by helmet to direct the skull growth. 6 to 9 months of age or more, we typically do larger cranial vault surgeries associated with the modified pie procedures potentially as well. Older ages, again, larger, more involved surgeries with absorbable plates and screws. Older children, we're talking about children who are 2, 3, 4, 5 and above. Sometimes there can be an unrecognized fusion of the sutures, whether that's prenatal or postnatal. These present with clinical symptoms and signs. ICP monitoring can be helpful to delineate whether they need treatment or not, and that's also important to realize as well. We counsel parents based on the risks: bleeding, infection, durotomy, CSF leak, need for reoperation. Of course, there are preoperative considerations with your team as well. For the endoscopic cases, we don't use arterial lines or central lines, but for the larger surgeries, we do use an arterial line at the very least. Complications, namely blood loss, potentially dural tears for CSF leak. So that's important, again, to counsel parents about. Late complications really deal with abnormal bone healing, especially those where surgery is performed at an older age. Again, morbidity and mortality are relatively low in the single digits. This is just an example of a child, a 3-month-old with scaphocephaly, sagittal synostosis that we treated endoscopically with a suturectomy. You can see a post-op scan that shows again the rounding of the head shape itself, and over time the bone grows back. So again, a lesser invasive technique that has worked well, and then the data has shown that too. And this is sort of some of the earlier studies comparing at least endoscopic versus open surgeries for sagittal synostosis. Again, as we expect, shorter hospital stay, lower transfusion rate, as well as a very good outcome in terms of not needing any additional surgery later on in life. Again, I am running out of time, so I'm going to kind of go through these slides very quickly. This is a child with right unicoronal synostosis. A preoperative imaging studies demonstrating that on the CT scan as well. There's, again, different techniques, but the traditional technique is releasing that suture and doing a frontal orbital advancement in order to correct the deformity. And these are just pictures demonstrating the craniotomy, the exposure of the craniotomy, the removal of the orbital bandeau, and then reconstruction. And you can see a postoperative image on the right demonstrating pretty good result. Sometimes you can see a retrusion of the affected side. So a lot of times when we correct this, we tend to overcorrect it in anticipation of that as well. This is a child with endoscopic unicoronal synostosis repair. Again, you can see the tip of the nose that's tilted as well. And this is some pictures post-correction with a pretty good result. Again, doing this early on also improves facial asymmetry and ocular abnormalities that can be seen as well. Finally, ending on metopic synostosis, again, associated with trigonocephaly and hypotelorism. The surgery itself, in terms of the technique, involves a bifrontal craniotomy and contouring. This can be done in a number of ways, whether using intrapositional bone grafts, flipping the actual frontal craniotomy to create a more round forehead, or using templates. All these are possible. These are just pictures in terms of exposing the bandeau and then reconstruction. We do these surgeries, the open surgeries, with our craniofacial plastic surgery colleagues. So it's a very good team effort for these cases. These can also be treated in an endoscopic way as well, with good results. Ending on building a craniosynostosis center, important to educate pediatricians in terms of timing of surgeries, particularly if your center does endoscopic cases, encouraging referrals as soon as possible, early diagnosis, and then establishing a multidisciplinary care team. These are just some resources that I bring up for those trainees interested in pediatric neurosurgery, also available online too. I want to thank you for, again, your attention for this opportunity. Feel free to contact me if any questions come up, and thank you again.
Thank you, Dr. Hasan. That was an amazing talk, and it gave quite an insight about how to manage patients with craniosynostosis. So I'm sure there will be a lot of questions, but as planned, you may write your questions in the chat, and we'll be taking as much questions as possible in the end of the session. So moving on, next we have another great professor of neurosurgery. He is a pediatric neurosurgeon who works in Costa Rica at the National Children's Hospital, and he'll be talking about shunts. So Dr. Adrian.
Hello, can you hear me?
Yes, loud and clear.
Yes.
Okay, let me share my screen. Okay, let's see. Hold on just a second. Something is going on here. Let's.
Ahmad, can you help, please?
No, I think it's on my end. Give me just a second. Perhaps you can take a few questions with Professor Syed while I'm setting this up. It's just something that I have to do here with permits on my screen. Hold on.
Okay, so in the meantime, when Dr. Adrian is addressing the technical issue, if we have a question or so, we can ask in the meantime. My question is that to Dr. Hasan Syed, that generally and traditionally we've been taught that in case of a single coronal suture craniosynostosis, you have to do a 3 centimeter wide cranectomy. And I have personally experienced that if you do a 3 centimeter wide cranectomy, strip cranectomy, it tends to fuse very early and you do not get the desired results. So is it okay to do or follow a standard protocol of 3 centimeter? And what is your personal experience or personal take on this?
Yeah, so I think you're referring to the strip craniectomy for endoscopic surgery, correct? So, 3 centimeters is a fairly wide craniectomy. I think there's variations. There's some, reports as well as experience with doing anywhere from 1 to 3 centimeters. I tend to try to do between 2 and 2.5. So 3 is wide, but the question is the surgery itself is one aspect to the care, but the rest of the aspect of the care has to do with the helmet, the cranial molding helmet, and that's really what's driving or helping drive the shape of the skull with the help of the brain growth. I think if you're taking 3 centimeters out and not doing helmet therapy, then there probably is a higher chance of fusion again. There are people, and I think I've talked to Adrian about this as well, just doing very large craniectomies and not needing helmets. But at least for the way that our center does things with craniectomy plus helmet, 2 to 3 centimeters usually does the job.
Okay, can you guys see my screen now? Can you see my screen?
Yes, sir, we can.
We can start with your presentation now that you're back.
Okay, so thank you so much. It is always a pleasure to participate, and I would like to thank Salman Sharif and the rest of his team. It's always wonderful to talk to colleagues on that side of the world, which I am very close to. I hold Pakistan very close to my heart. And I wanted to tell you today, about all these questions that we have regarding to shunts. Shunts have been around for so many years. And I think there are many practical questions because we still use them in many areas of the world. So, all right, let's see. So I think that the first question you want to ask is, why is Professor Caceres talking about shunts? Is he an expert? And in that realm, I would say that, what's the definition of an expert? An expert is that person who has witnessed or experienced and resolved all possible complications related to a medical procedure. And throughout the years, through my 20 plus years of pediatric neurosurgery, I can tell you that I'm still surprised. From time to time, my residents or other colleagues will perform things with shunts that still surprise me. And I have traveled this path and hopefully learn how to avoid many mistakes. So you have to learn from your mistakes and then being able to teach others how to prevent them. I think that's the key question here. So we should know that, we're taking the best decision for our patients is not always easy. And of course, now probably the most fancy procedure that we perform in neuroendoscopy is the ETB. It's becoming very common in many areas of the world. Optics are beautiful, and I think everybody will agree that neuroendoscopy has come of age and solves many problems related to hydrocephalus around the world. However, this technology, it's not always feasible to be widely available. And what I consider to be place in a shunt, I think it's very similar to traveling those roads in Pakistan, in the Hunza region. So it's a rocky road that you have to be prepared to travel. So how did shunt started? Well, John Holter was the parent of a child who had spina bifida. He was an engineer, and he was confronted with the problem of designing a shunt that would drain CSF from the brain of his child. In the process, he and some of his friends at work in a garage designed a number of components, and they came out with one of the most common components in medical technology, which is Celastic. This was Casey, his child, and he invented the bulb and spring shunt system in order to treat him. Sadly, and this is a picture from Life magazine, you can see his son Casey in the foreground and Mr. John Holter working in the background. The child was not able to survive before the whole shunt system was completed. But this invention by John Holter was able to change the lives of, I would say, thousands and thousands of children over the past 50 to 60 years since shunts were inserted. So the general principles, whenever you're working with a shunt, is the greater the numbers of parts or joints in a shunt, the greater the chances of having failure. So you should try to keep your shunt as simple as possible. And then it's always good to know that there's a limit on how small a shunt can be. You know, people will ask, well, why can't you design a shunt that has lower profile or that has smaller catheters? Well, in order for CSF to travel adequately through those pathways, well, there's a limit to that. The catheters would kink, or the shunt itself would not be able to manage the amount of fluid that we want. So for now, I think we're stuck with these problems of hydraulics, not only the diameter of catheters and the size of shunts and how to manage themselves. So whenever you analyze the causes of shunt malfunction, you'll see that in this endpoint graphic, you'll see that most of the causes of shunt failure are related to obstruction. Also, infection can be a big issue, and overdrainage seems to be like the third most common problem, and that's related to the type of shunt and the kind of hydrocephalus you're trying to treat. So very important is that we have many kinds of shunt valves. You can have adjustable and non-adjustable valves. We can add gravitational devices to shunts in order to prevent overdrainage. But the shunt mechanism itself, it's really simple. And I think this is the main idea. You should know that we have a proximal catheter, which is inserted into the brain and pulls out CSF fluid. Then we have a shunt system or a valve system, which will be able to retain a desired amount of CSF pressure within the cavity that you're trying to drain. And then all that fluid that goes past this pressure endpoint will be drained through the distal catheter. Now, it is very important to realize that you can have the valve system before or afterwards the chamber where you usually tap the shunt. And why is this very important? Well, because whenever you're evaluating a patient who has a shunt, it is very common, at least on my side of the world, that from the general physician through the nurses through everyone will try to, depress the shunt and let it re-expand. So if you have a, like in this case, if you have a system where the valve is distal to this chamber, you can have a completely blocked shunt, either at the valve or at the distal catheter. And by depressing the chamber, you're just letting fluid come in and out of the ventricle, but not through the shunt system. So you can be easily tricked into thinking that the system is working. There are other systems like the Pudens valve, which is quite common, or the Chabra shunt, where the valve is before the chamber. So when you depress it, in order for the chamber to re-expand, it has to pull out fluid. So just bear that into mind. I always tell my residents that whenever you remove a shunt from a patient, before discarding it, play along with it, take your scalpel, open the shunt, try to understand how it works. What was the system that was designed in order for it to work? So the next thing we want to know about shunts are proximal catheters. They come in many shapes and sizes. Some of them are pre-molded, some don't. We can still see some catheters around the world which were designed with these flanges, like the ones we're looking at in the first picture. Those were supposedly designed to prevent adhesion of the chord plexus. In the end, they were actually more adherent to it and became a nightmare to remove. So usually we have this distal slit system, proximal holes, which will drain fluid. And what are the the clinical manifestations of shunt malfunction. Well, as you know, it's an increscendo headache, nausea, vomiting, 6 nerve paralysis. And sometimes you can even see in kids that they can have nasal congestion and edema of the eyelids in children. Why is this? Well, this is because when intracranial pressure raises, we can see that the fluid will drain to the lamina cribriformis. So you can even have edema. Sometimes you can see changes in the pattern of play and school performance, but more often, shunt failure is a process that can sometimes can develop over a number of days. And the other thing that you should know is that we tend to think that intracranial pressure is somehow related to the rigid principles that we learned in the physiology book, in the Guyton or in the Gannon book, that CSF pressure is a longitudinal and a process, and that once it starts, it just keeps on going. And this is not what we know. We know that intracranial pressure will come up and down throughout the day, even with intracranial hypertension, and mechanisms will compensate. So it takes a little while to recognize patterns of shunt malfunction. So as we can see in these images, sometimes you can see widening of the sutures. You can see multiple catheters that have been left behind. Sometimes you can actually see on these shuntograms that the catheter has been disconnected from the shunt. And most often what people will recognize as shunt malfunction is where a catheter was previously placed. Now we see ventricle dilatation. And most often the case is that there's proximal shunt malfunction, blockage of those tiny holes in the tip of the catheter. And now you have a dilated ventricle. Of course, this is the ideal situation to perform neuroendoscopy, just by the simple fact that the ventricles have dilated. This is a very good chance. But if not, then it's also the main indicator that you have to check the whole shunt system to know whether the obstruction is proximal, which will be the most common scenario, or whether it's distal. So, as I said before, this is going to depend on the number of fenestrations, their size, how stiff is the material. Sometimes you place a shunt, a catheter into the ventricle, and you're certain that the catheter is in one position. And a good friend of mine has a saying that catheters have a mind of their own. So I think every seasoned surgeon has recognized that you can place a catheter somewhere in the brain, and then when you go on and do a CT scan over time, that catheter can end up anywhere, even far away from you originally planned, because it's completely dynamic. And the thing is that catheters have memory, so they tend to return to their pre-designed or manufactured length, which is a straight tube. And of course, you can always place a catheter in a small child that will go and grow, and then the catheter will become short and will pull out of the ventricle. And then again, based on the choosing of the pressure on the shunt, this catheter can become really close to the ependymal surface, and that can induce growing of fibrotic tissue into these tiny holes and block the catheter. Sometimes you place a catheter, and then over time, there's a new cyst that is formed within the cavity, and that pushes the catheter away, and then you have a shunt malfunction. So sometimes, there are cysts that can form within the cavity. Proximal catheter location has been one of the things that we have discussed over many years, and which is the optimal. Most of the time, what we try to do is to locate the tip of the catheter away from the choroid plexus. Of course, in clinical practice, there are two main patterns of inserting a shunt, and one is the precoronal borehole, and the other one is the occipital borehole. Sometimes when you insert a catheter, it will come like in the CAT scan image, it'll come like oblique to the trajectory of the ventricle, and that can be a problem. So one of the things that we advise is that whenever you're placing a catheter, always be mindful of the location of the choroid plexus and try to come in parallel to the greater length of the body of the ventricle in order to prevent malfunction. The next problem related to proximal catheters and shunt choosing is overdrainage. So as we know, we're completely dynamic. Whenever you stand up and you measure pressure, you'll see that for a few seconds, even in completely normal individuals, intracranial pressure can become negative. So now if you have a shunt system which is draining fluid, that negative pressure plus the drainage can induce collapse of the ventricle mantle, of the cerebral mantle, with formation of subdural hematomas. And this can be an issue. So you can have either slit ventricle syndrome, which is present in about 5 to 10% of patients. However, not everybody is symptomatic. You can have slit ventricle syndrome with, or slit ventricles without symptoms. And the whole idea of placing anti-siphon devices is to prevent the collapse of ventricles around the proximal catheters. The main idea of programmable valves is that you can actually start with a low pressure, and as the child grows, you can actually increase the pressure in order to prevent the collapse of the ventricle. This idea sounds very promising, but it's not always attainable because intracranial pressure is always very dynamic. And sometimes whenever you already have slit vents, then you have reduced brain compliance, which makes it very hard to treat hydrocephalus. So these anti-siphon devices are actually designed that whenever the patient changes their position from horizontal to vertical, this bulb will fall into the system and will prevent excessive drainage. Now, how can you actually prevent in a simple way? Here at our institution, 20 years ago, we tried to reason what was the best way to prevent this. And what we initially do is that whenever we have a small child, a newborn child with large ventricles, we place a low pressure valve. And then what we saw that was that, as you know, most than 50% of shunts that are placed in small children will require revision for all the aforementioned reasons. Whenever we would go to revise that shunt, we would change that to a high pressure shunt. Now, I know that what I just said goes against the dogma that has been taught for many years and by many surgeons that you cannot switch pressure abruptly from one to another. Well, our experience is that you can. And it's because there's an area where low, middle, and high pressure shunts actually share in common. And these changes of pressure are well tolerated. So we ended up looking a few years back in our series, and we found out that our symptomatic slit ventricle syndrome is less than 3% in our series. So I think that's a tip that you might want to look into. Now, the distal catheter, how can the distal catheter give you problems? Well, you can have a simple distal catheter obstruction, and the most common cause is whenever you have buildup of protein along the shunt, whenever you have either blood or high protein content and you have distal slits, sometimes you can have the accumulation of these debris along the slits of the distal catheter. And sometimes when you inject contrast into the shunt, you can see what we call the pregnant valve sign, which is basically an expanded tip. So many years ago, we looked into this, and as in many centers, we actually do not use slitted catheters anymore. We just cut the distal end and insert it. And we think this is one of the most easiest way to prevent distal catheter obstruction. Sometimes whenever you have an obstructed distal catheter, you can try to release it either by injecting fluid or by pressing the shunt, but always remember that the pressure that you exert by pressing on the shunt or trying to inject will never match physiological intracranial pressure. So at least in our center, whenever you have distal shunt malfunction, we always tend to go and revise that because we know that either it's infection or there's blockage of some sort at the distal end. Back in the day, we were thought that catheters should be trimmed at 30 centimeters before insertion in small children. And nowadays, we know that you can actually insert the whole length of the distal catheter into the abdomen of a small child, and as the child grows, the catheter will actually lengthen. Another thing that you can do in order to check for distal catheter patency is to do a manometry test. So here, we're checking a distal catheter. I'm injecting fluid in this racking manometer. And as we close the three-way valve, you will see in a moment that in this particular patient, we're closing the valve, and now we're going to watch how fast is the fluid draining. As you can see, the fluid is draining very slowly. It should be around 2 to 3 centimeters per second. So this is very slow drainage. This is telling us something is wrong with the distal end. And sure enough, whenever you have adequate distal drainage, this is the speed and pattern of distal drainage. You'll see it here in a moment as we close the three-way valve. You'll see that adequate distal catheter drainage is about 2 to 3 centimeters per second. So that's a good distal catheter that's functioning normally. Now, what is the residual pressure within the abdomen? It's between 5 to 7 centimeters. So you can see that the residual pressure that's left can be within those limits. And whenever you have an adequate distal catheter that's draining, you'll see that pattern of fluid, it's actually compatible with the 2 or 3 centimeters per second. Now, in that case, we pulled out the catheter and we found out that those lids were completely blocked by debris. So I think the most common way to avoid buildup of debris within these lids is just to cut off the distal catheter. Now, how do you insert catheters into the peritoneal cavity? In some centers, mini laparotomy is still performed where you can actually see the viscus within the peritoneal cavity and then insert the catheter. Sometimes we use a trocar to insert it, and by that, we do a much smaller incision in the abdomen. But then again, sometimes the catheter, if you're not careful enough, can either be left in the peritoneal space, or sometimes the catheter can pull out completely into the subcutaneous space, and you can see the catheter, such as in this X-rays, outside the peritoneal space. And the best way to see this, you can do a lateral abdominal X-ray, and you'll see the whole catheter that's underneath the skin. So other forms of distal end malfunction you can have in valves which are placed in the pleural space. You can induce pneumothorax during the insertion, so please do not use strokers. Always try to do direct fissure insertion, and whenever that distal catheter is malfunctioning, as in this X-ray, you'll see that fluid will build up within the thorax, and then you'll have a respiratory distress syndrome, which is restricted because of the buildup of fluid. So now you know it's the time to take that catheter out of there and place it somewhere else. What about abdominal pseudocysts? Abdominal pseudocysts, they usually appear late in the post-op period, and usually as the the omentum builds up this cavity around the catheter, we usually see it associated with infection. In some places, this is thought to be related to tuberculosis. It is not our experience. In most of our cases, it's related to staph epi. But yes, we can see that this can actually grow and reach significant volumes. So always try to rule out sepsis, and you can perform an ultrasound-guided cyst-step in order to obtain fluid for cultures before the next revision. So what else can happen to a distal catheter? You can have catheter rupture. So the subcutaneous trajectory of a catheter, usually, you go over the clavicle and into the abdomen. But as it goes through the neck into the head, there are different paths. Many years ago, people who were doing patients with spina bifida attempted to see if they could reroute catheters through the back of the thorax and into the abdominal cavity, and they found this pattern was associated to shunt malfunction. So the most common pattern is to come in the anterolateral aspect of the neck, and then above the clavicle and under the thoracic and abdominal subcutaneous space and into the abdomen. So whenever these catheters produce a reaction, they sometimes calcify, and then they become brittle and they can actually break. Sometimes when the catheter breaks, the scar that's formed around the catheter will continue to work as a pseudo catheter, but most often this will block, and then you'll have an acute shunt malfunction. And we know that this is related to patient activity as well. As a tip, try not to place any connectors below the neck, because then you will have a point of tethering, and while the child is growing, this will promote distal catheter malfunction. And we know that barium-coated catheters are more prone to rupture. And this is the buildup of calcium around the catheter that can actually make it become more brittle. And shuntograms, it's very easy to see that gap in between catheters. So always be mindful to, whenever you see a large collection of fluid along a shunt tract, to perform simple x-rays, and you'll see sometimes that the catheter, there's this gap. Sometimes we can actually see the whole length of the catheter that just disconnected and went away, and it's within the abdominal cavity. So that's also a good way to know that your catheter just slid down through the catheter tract into the abdomen. Now, another form of shunt malfunction that we get to see from time to time is hollow viscous perforation. Catheters actually, within the abdominal cavity, they're sitting against the viscous, and with the pulsation and the mass effect of the tip of the catheter against the viscous can actually slowly erode the wall, and then you can have a perforation into hollow viscous. So because this is a chronic process, it doesn't happen like overnight. There's always omentum trying to seal the inflammatory response around the catheter as it's leaning against the hollow viscous. So in a way, for you to understand, the hole is being sealed with omentum as the catheter perforates the viscous. And then you have this catheter that either comes out through the upwards or downwards, either through the mouth in this case, or sometimes you can have it that it perforates the cul-de-sac and comes out through the vagina, or it comes out through the anus. And you'll see this catheter. And I think the most common mistake that it's performed is that the general pediatric surgeon will perform a laparotomy because they think the viscous is perforated and they have to repair it. But like I said before, omentum has already sealed. So whenever they open the abdomen, they'll never find that tiny hole. So what we do is that we expose the catheter in the neck, we cut it, and then we just pull it downwards. And then we take out the rest of the shunt system and place an EVD. whenever you have a shunt malfunction that's related to infection and you have two or more organisms, and some of these are gram-negative bacteria, you can bet your distal catheter perforated a hollow viscous. Again, you can also place your catheter within the atrial cavity in order whenever you're running out of choices. And of course, having a catheter into the atrium also has its issues. You can have blood clots form around the proximal holes of that catheter. So we also like to to cut distal ends and just to place it, but always be mindful that sometimes you can have blood reflux up into the shunt system, but this is very rare, at least in our experience. Whenever you have a shunt that's within the circulatory system, you can actually have a shunt nephritis, and this is associated with ventriculoatrial shunts. Whenever you have what's called bacteremia and you have an alteration of the kidney function test in a patient with a shunt, then you should always suspect that this patient has ongoing shunt nephritis. So you should pull out the shunt and give antibiotics and look for another way of placing your distal catheter in some other cavity. So in short, I think you should always have a very good pre-implantation reasoning and try to choose which system is best suited for your patient and how can it works best. Try to avoid preventable complications. Be mindful that catheters sometimes have a mind of their own, so be prepared for surprises. And because you have a hammer, not everything is a nail. So always think that there are multiple ways of dealing with hydrocephalus, not only shunts. I think we could spend a whole day talking about all the related nuisance that you will find in shunt technology, but it's always a good way to rescue patients from hydrocephalus. So with that, I would like to invite you all to the upcoming ISPN meeting, which will happen in Viña del Mar in Chile. It will be held from October 15 to 19. It's a meeting of the greatest minds in pediatric neurosurgery worldwide. And this year we will plan to lower the rates for people from third world countries in order to promote attendance to this great meeting. So with that, I would like to thank you all. This is a photo taken at the beautiful Hansa region. And this is a photo from my country. And thank you everyone for your attention.
Thank you, Dr. Adrian. That was an amazing talk. And I'm sure we have a lot of questions because all of us keep running into all sorts of shunt problems. And every time we think that we have sorted out and then we come across something new. So now we'll be moving on to our next lecture. It's by Professor Dr. Anwar. He's a pediatric neurosurgeon in Abu Dhabi and a very senior one. And now he'll be telling us how to proceed the pathway for pediatric neurosurgery. So over to you, Dr. Anwar.
Yeah, I'm just sharing. Can you hear me?
Yes, sir. We can hear you.
And I've just put my slide on. Can you see my slides now?
Yes, we can see your slide.
Okay, good evening, afternoon, morning, Assalamu alaikum, namaste, bojo, and all my friends all over who is attending. When I talked to Salman, I thanked him for giving me the opportunity. And I said, what pathway? We should understand what is neurosurgical problem in pediatric age group, and that will dictate the pathway, okay? And this is most important thing to understand. Pediatric neurosurgery is very challenging. You can encounter a craniophagus twin where you will be involved as a part to separate a conjoined twin, or you will see a child who had just a growing lump in his head who is completely normal. Or you have to deal with somebody who did a procedure, as Dr. Adrian was telling, wrong procedure, wrong outcome. So, and if a child with craniosynostosis had a third ventriculostomy resulting in a pseudomeningocele and an improper closure of an encapsulocele, or they came to you very late where the treatment options which they get will not be of optimum what you want to give them. Or you will see weird pathology which you have no idea what to do with it. The first one is a child who has a cutis aplasia, such a large size, everything is exposed. What to deal with this? A child with a syndrome who had a encapsulocele not treated, or a child with multiple lumps. With this background, I would like to tell all my audience,
sir, sorry, Dr. Anwar, you have to enlarge your presentation.
I have enlarged it, my friend.
Just go to
it's not
slideshow, Anwar. The slideshow.
Slideshow.
At the
It's
bottom,
right?
Stop live. New share.
no, sir. At the bottom of your presentation screen, where it's written 50%.
Next to where it says 50%, where you can enlarge and make it small on the right bottom.
Salman, this is my first time. So, okay, I'm going to start.
One second. You can reshare, sir. I'm stopping your presentation. You can reshare.
So should I end my show?
Reshare. Now you can reshare.
Look, well, okay, I'm share screen, yeah? This is my presentation. Okay, I'll go up. Okay, increase the size of the presentation. It's gone very.
Anwar, where you're reducing the size, next to it is slideshow. Just press on that. No, just go slightly.
Yeah, I got it. Is it now? Right now?
Yeah.
Okay.
Maybe press again.
But I've got the whole screen on my presentation. How can I get rid of that? Okay, no worries. Let's understand.
We can't see this. So,
Yes, sir, we cannot see.
So maybe you can do it from the top. It says slideshow on the top where it's home. Go next to animation or review, in the middle of animation and review. On the top left. You
Stop video, mute.
No. Where it says, where is home on the left? There is insert, design, animation. So next to animation, there is slideshow on the top left.
No, Salman, I'm not seeing that in my screen. I don't know why.
Okay, so maybe can you reduce you have put it up to 100%, just reduce it to 50% first.
Okay, I'll stop my. It's 100% at present moment.
So reduce it. Thank you. And then go on to press slideshow on the left of it.
Slideshow. Yes.
Yeah.
Is it better now?
Still not doing it. So maybe do it from the top left where it says home, insert, design, animations on the top left.
Top left, home, insert,
And
design,
keep
animation.
Keep going.
Yeah, there's a slideshow now.
Yes.
There's a slideshow. Yeah, I did it.
Yeah,
Is it
just
all
go
right?
from the current slide. Do it from the current slide or left. Go again on the left. Top. Go above this. Go no. Just go come down a bit. No. Just in the same area. Go on the top left.
Yes.
Where it says
Slideshow.
from. No. Then it says from first command it's giving on the left side is from beginning or from current slide. On the left, down, one down. Yeah, that's it. Just press there.
It's better now.
No, sir. This won't work.
I think it's related to the way he's sharing his screen, because sometimes you can share the whole screen in the options from Zoom.
Yeah, the slideshow is going at the back, at the background. So
look, I'm back on the video.
Anwar, can you send this to Ahmad and he will then share, if that's okay with you?
Oh, okay, just 1 second. Sorry for this. Okay.
No problem.
So in the meantime, I'm just going to answer some of the questions. We have a question here that says, for shunts, when would you do ventricular atrial or ventricular pleural shunts instead of BP shunts? Now, that's a very interesting question. Whenever the shunts were started, initially ventricular atrial shunts were very popular. And then gradually over the next 15 years, putting the shunt into the peritoneum became widely popular, and now it's the most commonplace. I think the most common scenario is that whenever you have a shunt that became infected and that you have a now non-absorbing peritoneal cavity, sometimes you have kids who had appendicitis or some other abdominal inflammatory process, and now it's not absorbing well the CSF. We sometimes place catheters in the pleural space in order to let the peritoneal abdominal cavity to rest while we're placing.
Salman, yes.
Just mute yourself.
And by doing that, by placing the catheter into the pleural space, we'll give it enough time. We know the pleural cavity, usually it's not a long-term resource. In some kids, surprisingly enough, they can go on for years in the pleural space. But at least in our experience, it's a temporary measure. So after a little while, you can actually reinsert that catheter into the peritoneal cavity. Now, if you've had a child, and I'm sure that many of you have encountered this, patients who've had multiple shunt infections, recurrent infections where abdominal cavity is no longer usable, or they have an abdominal problem which prevents that, you use the pleural cavity and then you're not longer able to use this, then at least in my center, atrial shunts are our last resource, because in those patients who had multiple infections, you do not want to place a catheter into the circulatory system if there is the chance that there's still ongoing infection. So we check and check time and time again to make completely sure that cultures are negative before inserting the distal catheter into the atrial cavity. And we always monitorize in order to avoid long-term infection and the chances to have endocarditis.
Dr. Adrian, what's your take on ventricular pleural shunts? Do you think patients tolerate pleural shunts well for long periods of time, or you only use it as a temporary measure until the abdomen becomes available again?
Yes, like I said before, we usually use it as a temporary measure, you know. And of course, we've had patients that we placed the catheter into the pleural space, and we thought this was going to be, you know, for a few months before the abdomen was ready again. And then they go on for years. But of course, sometimes there's this pleural effusion that is getting in the way with normal breathing, and then, you know, it's hard. I think that the most daring problem with shunts is infection. And on this, we can do a future talk, and there's so many possibilities. So Christopher Nat is asking, can you please explain again the reason for nasal congestion and eyelid edema and shunt malfunctions? So yes. So in small children, remember that CSF, as intracranial pressure is raising, will try to find outlets. So there is widening of the meningeal spaces, not only within the spinal rootlets, within the dura, but also sometimes pressure is so high that it drains through the lamina criviformis of the ethmoid. And you'll see kids who come in with puffy eyelids and even a puffy nose. And sometimes people identify this and think that the kid is having an upper respiratory tract infection, and that's why his nose is kind of runny and drippy. But you'll be surprised in how many cases you go on, revise that shunt, make it work again, and within 24 hours, the eyelid edema is gone. And this is just, that it's amazing how in some of these kids, you can actually have intracranial pressures that go about 50 or more, and they're still talking and walking around. So the pathophysiology of intracranial pressure, especially in children, is very, very complex. Number one, you should always remember that in kids who are lesser than 3, CSF production is not always predominant on the plexus. It's produced by not only the choroid plexus, but also by the parenchyma, and it's not always absorbed through the sagittal sinus, but it's also absorbed, but through what we now know it's the glioneural system, which is this perivascular system that goes around large vessels, and it's actually a way of a parallel pathway for fluid absorption. So as the cranium becomes rigid, then you rely more on the drainage through the venous system. But have you always wondered why, as the pressure raises, there is no more fluid draining into the sinus? Because, the book says that this is like a one-way system, that it just drains completely, right? But the arachnoid granulations within the sinus, it's an active transport system. It's not pressure mediated. If not, fluid would just go into the sinus directly. But it's a system that's dependent on fluid secretion into the sinus. So you have a limited number of aptic units secreting fluid into the sinus. So this is the basis for explaining subdural effusions of infancy and a number of other problems. But that's a completely different talk. I think Professor Ahmad is ready for his lecture now.
Ahmad, what's happening? Are you guys ready?
Yes, sir, we can see your screen. 1 second. Let me unmute you. No. 1 second, sir. Yes, sir, we can see your screen.
And I have something on my screen. How can I remove that? Okay. Okay. Can everybody hear me?
Yes.
Okay. Sorry for this interruption. Now, as I was telling you that pediatric neurosurgery is not what's the level. We have the world population of about 8 billion, and of that, under 15 years is patients under 15 years, and it accounts for 26%. Now we see the ratio of world neurosurgeon is only 50,000, and of that, those who are practicing only pediatric neurosurgery turn out to be only 5%, nearly about 3,000. And in the world, the number of procedures done is about 143 million, and of that, almost 21 million are neurosurgical procedures. So we as a neurosurgeon have a lot of volume of cases. But
Anwar, I'm sorry.
Yes,
your slides are not moving, so you'll have to go one by one. So go on to the slide that you're on, please.
No, I'm still on this slide. Can you hear the facts? Yeah.
No, we are seeing the main slide on which your name is there. We are not seeing any the following slides. So go on to the next slide. Just click on the slide itself on the left.
Yeah, I'm doing that. Okay. Next. Is it showing now?
No, you have to change yourself by clicking on
slide. Sir, can you press Alt R? Can you press Alt R?
Alt R, yes, I did it.
No, it's not working.
No, just click on each slide one by one. So click on slide 2 first. We have not seen that slide. On the left.
No, I'm going forward on this.
We can't see the slide change there.
No, maybe he's,
Can you see it now?
no, sir.
Oh dear.
Ahmad, did you not
Screen
get
resume
it?
share. Can I do that now? Can you see now the movement of the slides?
No, sir. Sorry.
No?
Reshare with first close your presentation, then restart and then share again. I'm stopping your
Okay.
presentation.
Okay. So now I'm starting my presentation. When I go to the presentation, share screen, my presentation is on the right corner. Should I share it?
Yes, sir.
Okay, can you see this?
Yes. Yes. Then click on the slide one by one.
Okay, it's not the full slideshow, it's just a half of it.
Yes, sir.
All
That's
right.
fine. Yes, sir.
That's okay, but you just need to click on the slide on the left. On left.
Yeah,
Okay.
but it's moving on there, but it's not moving on the screen. Can you see it now?
Now we can
Yes,
see
it's
general.
moving.
Yeah.
You can see it's moving.
Can I
Okay.
proceed?
Yes,
Sorry.
Yes, please.
Okay, we got the flavor. Anyhow, the most important thing we have to understand is that we all are neurosurgeons, but we're not groomed to become a pediatric neurosurgeon. And what a pediatric neurosurgeon has to do is that he has to be a pediatrician to practice the pediatric neurosurgery with his expertise. And I clearly found that pediatric age group is such a variation of age group where your anatomy, physiology, your metabolic response, everything is changing. And we clearly have to think now from the child in a fetal stage are needing neurosurgery. So you need to understand what are the risks and benefits at that stage. Then is a neonate, which is 1 to 28 days of birth. And which is also important that what time you are born, either you are born in a preterm or you are born a full term or 28 weeks and that is the age you get neonate. Then is the infant from 1 to 6 months. And that is also related not to a particular time when you are born, toddlers, preschool, school-age child, and adolescent. The first four groups are where the dynamics and the physiology is changing, the skull is changing. We have buffers of cushions like open fontanelle, open sutures, which is different in the preschool, in the school-age children. I just go fast that neonates is a very specific group. It is not only when you are born, what was your weight when you were born, and whether you form in the 28 weekers or pre-28 weekers or 28 to 37. And this has a huge implication on planning your intervention. Just for example, you have a myelomeningocele child and who is born in 29 weeks, and he has a small membrane which is intermittently leaking. But this age and the weight is only less than 2 kilograms is not the right age to do a definite closure. What options you have, and that is something, the thinking process you need to develop. Now, I'll just show that without discussing the fetal medicine in pediatric neurosurgery, it is an injustice to the parents who are going to deliver a child with a neurosurgical problem. And fetal medicine gives us a clear idea about what is the pathology we are going to deal with this child who is still in the intrauterine period. What are the possible consequences of that? And as you see, this first slide shows a significant Dandy Walker, a myelomeningocele with hydrocephalus. The second is an hydrocephalus, like an hydranencephaly. The third is that a child who had a very malformed brain, and there's a child with brain tumors. I will skip this. This is a fetal surgery showing a repair of myelomeningocele. But unfortunately, even though the pathology age is different, but the brain has got the 3 compartments where the volume of brain, blood, and CSF has to be balanced. And this in turn dictates the pathology. I will take a very, I will take a very common example. A child who is born with prematurely had got intraventricular hemorrhage. and how you will deal with this. This is very important to have a plan. You need to know what was the reason. You have screened the clotting profile. You need to plan and give the plan to your pediatrician that how they are going to monitor the head circumference, how frequently the tapping has to be done, and what is the volume of blood stained CSF they have to take. And it's very simple to remember that you need to wait when the child reaches the age of 2 to 2.5 kilogram, his CSF has to be less than 2 grams, and he had no infection, and his gestational age should be minimum of 36 weeks. How do you buy this time? You keep on doing repeated tapping. Repeated tapping is very important, but you also have to assess, you cannot give risk of infection. So you need to plan that if the head circumference is increasing more than 1.5 centimeter, the child needs a tapping. But if the tapping is more frequent, then you have to give them a ventricular access device. Depending on your setup, either you give them an external ventricular drain where you can monitor, your nurses can deal with this, or give them a ventricular access device, which is an Ommaya reservoir, and which is a safe options to tap in regularly to get your child to an optimum level. The next thing is that what is the heart of pediatric neurosurgical practice? Traumatic brain injury, hydrocephalus, brain tumor and spinal cord tumor, neural tube defect, skull size and shape, which has been very nicely discussed earlier, and the miscellaneous problem which we can encounter either as a result of treatment or something has happened as a new pathology. The assessment of pediatric neurosurgical patient is the same. Glasgow Coma Scale give you an idea how urgent is the treatment, because GCS still has got a high implication on deciding your treatment. The next is that what are the neurosurgical intervention we can offer as a pediatric neurosurgical? Make it clear, like you have to either give them a drainage or diversion of fluid, or closure of an opening, either a neural tube defect or any encephalocele. Removal of tissue can be in the form of blood clots, brain tumors, opening or fusion, which is mainly craniosynostosis, and miscellaneous could be infection, head injury with various stage of injury, skin lesions, and complications of procedure. Salman, my presentation has changed. So this is just an example of a child who had sustained a head injury, and that has resulted in subdural. But unfortunately, the child could not be followed up regularly, and then he come to your clinic. In a late presentation, and what you understand is that they have developed a significant subdural hygroma with a significant compression of the brain. And this in turn leads to a significant brain compression and poor milestone. So it's very important that when you follow a pediatric neurosurgical patient, you have to have a plan for their follow-up. It has to be planned within the team. So before discharge, they can very well be seen. The second important thing is that children with head injury have different size of head according to their body volume. And the larger head in the early age will have a higher implication of severity of head injury. So you should have an assessment that a child who is under 2 years will have a significant effect of a fall from a 1 meter height as compared to a preschool or a school-going child. The second important thing is this. Your patient is not only with a neurosurgical problem, your patient is also as a whole. This is a patient referred to us with a head injury associated with hydrocephalus shunt infection. And the focus was only on his neurosurgical part. But if you see this patient, what was happening to his general condition, the malnutrition, the contracture he was developing, and he was in an ICU setup. So as a pediatric neurosurgeon, don't just be focused on the pathology, take your patient as a whole, be responsible for every aspect of your care you give it to him. Anesthesia is also very important in your pediatric age group. because when you do offer them surgery, you have to plan who's your anesthetist, because who will be giving your child a safe anesthesia for many hours? Our procedures are long. The ventilation can be a prolonged ventilation is a problem. The volume of blood loss has to be taken, hypothermia, the risk of seizures, all this has to be planned, and it will definitely have a very good outcome on your patients for surgical intervention you are planning. And you can see the chaos you get when a child who had a major procedure to be planned for surgery. So be patient, don't give your anesthetist ample time to fix the tube in every orifice and have good IV access, because this will help you at the end of the surgery. I will also go here. Scalp injury. The scalp injury is very often missed in children with pediatric head injury, because the moment they enter the ER, they have got a huge dressing, and as it's not bleeding profusely by a tight bandage, it's never been bothered to look into. And we have received patient hypovolemic where the scalp has been bleeding and no attention was given. The second is that don't go on the look of the child. It should always be a systemic assessment from the clinical picture, his GCS, and his CT scan finding. And in this child, if you see, he had a horrible bilateral raccoon eyes, unable to open, but he was obeying commands. So it gives you time to decide what should you do, whether this should be monitored in the ICU or ward or HDU setup. Second is that in neonates and infants, this bleeding or the extradural or subgaleal hematoma or head injury is not the problem. The problem is the volume of blood loss these patients suffer. As Adrian has very clearly discussed, hydrocephalus is a dynamic process, but you also have to do the best when you are planning for shunt. You need to see the ventricles, you need to see the cortical mantle, and you find the best safe site where you can put your catheters safely. These all has got a long-term implication. If you see there, you don't need to think, but here you need to plan. What are you going to do with this multiloculated ventricles? What are you going to do fenestration and then put a shunt? And this is very important, and this time again has a very high implications on the success of shunt. This is another challenging case with the hydrancephalate. Yes, you want to put a shunt, but how? Where should be your incision? Is it in the dependent part? Whether its skin thickness is enough? Make a good flap. Don't compromise the vascularity of your flap in such a large head, because they often have a skin necrosis. And when you have planning to decide from frontal or postoparietal or occipital, I prefer frontal. Will give you a good cortical mantle and a good confinement to your shunt ventricular catheter, and which will in turn help for your shunt function in long term. The another thing is that don't carry it away that every cyst or lump in the brain is a benign thing. You have to think very clearly out of the box. And this is a classical example of a child who was had a seizure. He had a very well-defined cyst. And in the history, the catch was that he often used to play with dogs. And the diagnosis was with the history, which was confirmed with the agglutination test, and then we found this picture on the operation, and it was really clearly delivered out. This is another pathology where here you can discuss about the prognosis treatment. Here you have nothing to offer. A brainstem diffuse pontine glioma, you have to be sympathetic to the patient's parents and talk to them the poorest outcome you can encounter. In this, you have to see what is the pathology, what are the effects of the pathology. There are three effects on this patient. One is that the tumor itself. The second, it will affect the hormonal function of this child. And the third is his vision. And these all three has a very great implication on his long-term outcome. No pediatric neurosurgical talk can be avoided with the myelomeningocele. Myelomeningocele is a very interesting problem. You get called from the labor room when the child is delivered. Don't be panicked. Tell them to clean the child, send you a proper picture, and you see what is the difference between this and the picture on the right. Then you plan your repairs. You should always have plastics and people who has helped you in the past to decide about the closure, and some funny ideas that preserve every single millimeter of the skin. And in this case, we just approximated the skin and used this whole sac as a partial thickness skin graft. And what we achieved was a very decent closure in 6 to 8 weeks time. The same goes with this child. Picture from the labor room, picture in the OR. And we have this repaired and it worked well for the child. Sometimes you have a very funny presentation. This is a patient with a large swelling. It was antenatal diagnosed, delivered by cesarean section, and it was a metancystomalocele where the whole central canal was protruding out, and it's a large cyst. It did not require any, you just do a significant close dissection of the spinal canal and then close it with the skin defect, and later on do a lanative imaging to find out what could be the residual effect of this lesion. Sometimes you will be across with a large swelling on the head, but the child is very well, his skull is still growing. And in this situation, the best management is to monitor them, observe them, and image when there is a change in the neurology or the new symptom. You don't need to keep on imaging, doing CT scan and MRI every 4 to 6 weeks or 3 months. Sometimes education of the patient is very important. You have shunted a child who had shunt placed in, but what you found that the child was very cranky, mother was tapping the child, and it resulted in a displacement of the shunt in the cranial wound. And we have to revise this shunt within few weeks. This is sometimes, if you're not careful how medial or lateral, you can cause damage to the occipital artery, which resulted in a pseudoaneurysm, and which was the reason for partial obstruction of the shunt, which is my case. I was blamed, and I just excised the pseudoaneurysm, and then the shunt was functioning. This is another interesting case. Children are born with cephalohematoma, but unfortunately, sometimes the hematoma does not resolve to conservative management. If your pediatricians are asking or the gynecologists are asking for help, please help them. This is a tug of war between the pediatric surgeon and neurosurgeon, and it was left to a stage where it got infected and formed a purulent discharge, and then required a major surgery to excise all these abscesses and a prolonged stay in hospital. This is interesting. Don't go on scan only. Always assess a pediatric patient yourself. We was send this scan to come in, but when we saw the child was within himself. He was opening eyes, he was moving, he was seizing. And what we did was just did multiple aspiration, and finally the child has survived and has done his first birthday. There were too many things to show, but I'll cut down. Sometimes you find unusual pathology referred to the pediatric neurosurgeon, but what you see is not your trend. You could get involved with plastics, and here is an infected bone flap. In pediatric age group, you should never try to save the bone flap. Be bold, remove open the wound, remove the flap, try to save it, and go early, and you will have a very decent outcome. At the end, I will just say, I'm sorry for the disturbance. Always remember, in pediatric neurosurgery, there are 3 pairs. One is the peer pressure you get when a patient is referred by them to you. They want to see a patient in the first 24 hours or first hour. Reassure them, assess the patient as soon as possible. The second is the parental pressure, because you have to communicate very well with what you are going to plan and what is going to be the future outcome. And the intracranial pressure, which you all very well trained to deal with it. Always remember when dealing with a pediatric neurosurgical patient where you are starting and what will be your finish line. Pediatric neurosurgery cannot be practiced standalone. You need a very disciplined, multidisciplinary team with all the skill which can improve your outcome. And I find that it is better when you are doing pediatric neurosurgery in a pediatric hospital. And yesterday I quote that it is like eating Chinese in a Chinese restaurant rather than a good restaurant. Pediatric nursing plays a very important part in the outcome, and it starts right from the inpatient to OR, and all this improves the outcome. Outcome depends also on the neonate's comorbidity, pathology, and the time you have been seen. As I said, sometimes they present very late. And it is difficult to predict neurological outcome in early stage of brain and spine cord development. As you know, the anatomy is changing, the physiology is changing, and few complications can affect their outcome. Thank you very much for your time and patience.
Thank you, Dr. Anwar. That was an amazing talk, and we have been fortunate enough that the session was also moderated by Dr. Imran Bhatti. He's a neurosurgeon operating in Islamabad, and he's done his pediatric fellowship from UK. So he's a trained pediatric neurosurgeon. So we'll ask Professor Salman and Dr. Bhatti to give some comments regarding the current session.
Yeah, I think I don't need to give comments. If at all anything, Hasan Syed and Adrian need to give some comments from here.
I guess, I just want to a couple comments. First of all, I think that these were great talks. It really shows the breadth and depth of pediatric neurosurgery. I think it's really important for us all as neurosurgeons to recognize that the pathologies within the pediatric population is really important to recognize, and it does require a level of thinking that we have to pay particular attention to those pathologies. Again, I want to thank you for the opportunity, to speak, to work with the colleagues in Pakistan. It definitely means a lot to me, and I appreciate it.
Dr. Imran, any word from you and regarding the young neurosurgeons who want to train in pediatric neurosurgery?
Yeah, thank you very much for inviting me on the Zoom meeting, and although it's a short notice, but enjoyed all the talks, and it's a good effort. I think with regards to developing neurosurgery on the pediatric side in Pakistan, I'm just landed here 6 months ago, so I'm still trying to find my feet. So hopefully, in time we'll just collaborate and see what's the best in terms of patient outcome and how to establish the services. I did have some experience in the Middle East. I established one of the pediatric units there, so I can understand what are the difficulties, and in my current hospital as well. Just to on the right forum, maybe I have to say a few things. So far my experience, because it's an independent setup where I'm working currently, there are a lot of scope for improvement with regards to team building, with regards to it's not only about pediatricians and neurosurgeons. I think again, I've not visited many centers in Pakistan as yet, but I feel that probably pediatric neurologists play a big role in terms of patient management. I did have problems with regards to, even imaging, establishing the neurosurgical services properly in tumor cases, for example. I was trained at Liverpool, and I worked as a consultant in Cardiff. So our practice was, to do complete resection of the tumors, or attempt to complete resection of the tumors, doing post-op MR scans, which I think it will take time for people to persuade the importance of outcomes in that sense. I did have problems with pathology even. We are lacking on some resources. With regards to craniofacial, I believe there are a few guys doing sort of independent remolding surgeries. But again, I'm not aware of, so I have to be excused for that. I'm not aware of any setups where it's like streamlined in a way for the majority of the patients. So I believe my initial impressions coming back to Pakistan after 2 decades, probably, things are moving forward, and I have yet to see and personally probably visit some of the departments to see how we can collaborate. And I'm sure people are doing a great job. And our international presenters, of course, they can contribute to better develop a service.
Thank you, Dr. Imran. That was quite insightful from you. And we hope that you build a complete pediatric neurosurgery unit and help other institutions across the country as well in pursuing this. And rather than pediatric neurosurgery being a domain being taken by general neurosurgeons, it should be subspecialized to dedicated pediatric neurosurgery. So I think so it was quite important talks today, and I think enjoyed it and learned a lot. I think we all enjoyed it and learned a lot. So I think with that note, we'll be ending the session. So thank you, everyone. This was a great pleasure watching you all, and we had a great attendance. Thank you for your time, presenters, and hopefully we'll have another session sometime soon. Thank you. Goodbye.
Thank you.
Right.